Good evening, everyone, and a very happy new year because this is our first episode of PRISM Talks for this year. For those who've not been in PRISM Talks, was evolved, started by Chennai Liver Foundation from Chennai, where PRISM stands for Progress in Research, Innovation, Science, and Medicine, and we try and bring varied subjects and topics to your desktop. Um, and this is our ninth edition. We've been doing, of course, December we took a break because it fell on Christmas Day, so we took a break. But I think we are a bang. We are off to an amazing start because the pressure is on the speaker today because it's the first time ever that we've got 100 attendees even before the talk started. So I think this shows the importance of this topic, and it's a privilege to welcome Dr. Archana, a very good friend of ours, and we work together in various aspects. Welcome and good evening, Dr. Archana.
Good evening.
Before I introduce the speaker, a few housekeeping things is, of course, as you've noticed, the delegates or the attendees, you will be on mute. If you have any questions in between, please feel free to use the Q&A box so that we can, of course, Dr. Archana would be able to read the questions in the Q&A box. At the end of the session, there will be a survey which will be, again, the link will be sent in the chat box. We request all of you to fill up that so that one is we can improve on how we deliver the whole PRISM Talks. And of course, for any new topics which you would like, we'll be more than happy to get speakers for the topics which are very, very popular. So with that, it's a delight again to invite and introduce Dr. Archana, who's got a postgraduate degree in community medicine and who's a scientist E at the ICMR, where she leads epidemiology and implementation science research projects in non-communicable diseases such as CVD, diabetes, fatty liver disease. And this she does in close collaboration with many state organizations, state governments, international organizations like the WHO, CDC, etc. She's a course coordinator and senior faculty member, India EIS Advanced and the Intermediate Field Epidemiology Training Programs. Previously, she held a position in ILBS or the Institute of Liver and Biliary Sciences in Delhi as a lead epidemiologist at the WHO Collaborating Center for Viral Hepatitis and Liver Disease. She's led several research projects, including the statewide STEPS survey for Tamil Nadu and a survey to assess the preparedness of health systems in 8 states for implementing the MASLD or the Metabolic Associated Steatohepatitis Liver Disease guidelines. She currently leads studies aimed at incorporating and continuous quality improvement within NCT programs at government primary care systems in the states of Goa, Telangana, and Punjab. And then this goes on and on. Of course, I have to mention that she contributes a lot to our work with Chennai Liver Foundation and the ICMR and CLF work together in various aspects as well. Dr. Archana, the stage is yours.
Thank you, Dr. Vivek, for those kind words of introduction. So allow me to just share my slides. I hope my screen is visible and it is in the slideshow mode.
That is correct, yeah.
Yeah, okay. So a very good evening to all of you who have joined online. And so as I understand, the pressure is on me, but this is a very interesting and important topic close to my heart. So one of the important things that clinicians as well as public health researchers need to know is once an article is published, what's the right way to read it? And how do we really interpret the evidence that is present in the manuscript into our day-to-day clinical practice or public health practice? So usually when we look at any research paper as a clinician or a researcher, there are few questions that come to our mind. Like, what does the result really mean for my patient or for my population? Can I really trust the results of this particular trial? And who do the results actually apply to? These are few of the questions that actually come to the mind of researchers or clinicians who read trial papers or, RCT papers. So one of the things that commonly people think is when you actually critically read a paper, a lot of people think that it is mere criticism from the reviewers, but that is not the case. Critical appraisal is not mere criticism. Why do we really need to do critical appraisal as clinicians or as public health researchers is many a times the authors may ignore the weaknesses of their study, or sometimes there is a case where they will overinterpret the results. You need to also really know whether the evidence that is presented in the paper is a strong one, or are there a lot of weaknesses in design in the way the analysis was done. And finally, as clinicians and even as public health practitioners, we need to know who can we apply these results to. So a lot of the times, just mere casual reading of the paper is not useful to answer these questions. There needs to be a critical appraisal. So not only when you wear the reviewer's hat, normally when you read a manuscript also, you should be actually paying a lot of attention to what the manuscript is saying. So what exactly is critical appraisal? Critical appraisal, as we were just talking, is carefully looking at research work that is published, systematically examining it in order to understand what value will it add to the existing pool of evidence, how relevant is it for the particular context wherever you are working, whether it be a public health context or a clinical context, and mainly to judge whether whatever result is being given in the manuscript or the paper is trustworthy or not. So this is why many of us need to do critical appraisals, and we may not have thought of it as critical appraisal, but definitely we will read manuscripts with a closer view on all these questions. So suppose if I am a clinician or a researcher who wants to read a research paper which is presenting the results of a trial, what are some of the important questions that I should ask before I start reading the trial? So the first and most important question that I need to ask is, what is the research question which is being answered as a part of this trial? Is that research question clearly defined? And is it relevant to my context? So these are the two things as far as research question is concerned that you should first think about. The next question that you should ask is, can the results be trusted? And how do you know if the results can be trusted? Or in other words, are the results valid? The only way to know that is to know if the methods were good, if the methods were valid. The next question that you need to know is, what does the results presented in the trial actually mean? Is it showing a very big effect of the new intervention? How precise is the effect measure that the authors have studied? So these are some of the things that you need to look at in the results section. Finally, you also would like to know who are the results applicable to. Now that I know that this is the result from this particular intervention, to whom should I apply? So these are the 4 key questions that before you read any trial manuscript, you need to ask yourself, and you need to get the answers at the end of reading the trial paper. So first, let us look at what should we look in depth when we look at the research question. So the first is, let us say we are taking an example of a research question, which is vitamin E for people with non-alcoholic fatty liver disease and hypercholesterolemia. Now, when I simply say vitamin E for people with NAFLD and hypercholesterolemia, it's not very clear to me, right? So what is not very clear? I'm not very clear who the research question is trying to study. In other words, who are my research population? Of course, I know that the trial is talking about people who have metabolic dysfunction associated steatotic liver disease, but is it talking about people in which stage? Are only people in the early stages of steatosis included, or all stages are included? Do I know if the complete spectrum of NAFLD is included? Does it include only steatosis, or maybe people who also have inflammation in the liver, or maybe even cirrhotic people, or maybe even people with carcinoma? Are the patients having other metabolic conditions? We saw that, there was one like hyperlipidemia. So are there any other comorbidities like diabetes, etc.? So once you read the research paper, you should be very mindful of who are the study population for whom for whom the researchers are actually done this research work. So first is to note these things about the study population. Now let's look at an example of a published trial. This is a trial which is published in one of the nutrition journals. And here, very clearly, the authors have mentioned, if you can read my screen, they are talking about what are the age of these age groups which is included, whether both genders are included. Who are these people? These are people with ultrasound proven NAFLD who have also got mild untreated hypercholesterolemia. And where have they defined hypercholesterolemia? Yes, they have defined the ranges of the values that they have included for total cholesterol or for LDL. They have also mentioned that the patient should not take alcohol more than 20 grams per day. And they have also mentioned that what is the range of liver enzymes within which they will include the patients. So the first thing when you read any research paper or trial paper is you should move your eyes to who are the study population who are being studied. If this is the inclusion criteria, who are the people whom they are excluding? Which is what is coming in the next slide. See, they have excluded any person who in the past 3 months has actually taken any treatment for hyperlipidemia, any anti-hyperlipidemic treatment, or has actually taken our intervention of interest, which is vitamin E. And they are also excluding people with previous cardiovascular events or hepatitis. Now, why it is very important to know this is, you need to know which population the research question is pertaining to or answering for. So that is the first thing you read when you read a trial paper. Then you also read what is the intervention that is being given. Of course, you know it is vitamin E, but from that particular thing, you don't know what dose is being talked about, what formulation they are going to try. For how long are they giving? Is it for 3 months? Is it for 6 months? Is it for 1 year? Are they going to add anything other than vitamin E to their intervention? So after looking at the study population, the next thing that you need to look at is what is the intervention. When we look at the example that we have been following, in this case, they have very clearly said that they are going to give mixed tocoretinols 200 milligram twice daily for a period of 1 year. And they have also given the composition of each capsule. What do they mean by mixed tocoretinols? What milligram of alpha, gamma, and delta tocoretinol will be part of this 200 milligram mixed tocoretinol capsule? So they have told you the dose, they have told you the formulation, they have told you what it contains. They have also told you for how long they are going to be taking. So this is the next thing, and why this is important is many a times the interventions at a certain dose may not have the same effectiveness as interventions at a higher dose or lower dose. So whenever you're looking at interventions, even if you look at community level interventions, you need to know, let's say if it is a lifestyle modification intervention, you need to know what is the frequency at which it is given. Suppose if you are going to give even a health talk, how frequently it is given, for how long is it given, and what is the dosage. These are important things to understand because the results that you're going to find are for intervention package which is comprising of this. So first you looked at who are the study population. Then you looked at what is the intervention being given. The next thing you need to look at is what is the intervention compared against. So what is the comparator? In this study, if you have closely looked at the previous slide, they have a comparator which is a placebo. That means it does not have any active ingredient. Sometimes trials can also compare with standard of care or standard treatment. In other cases, there can also be other active ingredients. Maybe there are trials which tested vitamin E with metformin or vitamin E vis-a-vis pioglitazone. So you need to know what is the effectiveness of vitamin E measured against. Is it a placebo with no active ingredient, or is it already approved standard treatment? The next thing that you need to look at is what are the outcomes for which I am testing the effectiveness or efficacy of vitamin E for. Because Some of the times, some interventions work only for certain outcomes. For example, some intervention only will reduce the liver fat score or may only bring down the liver enzymes by a little bit, but may not have any ultrasound proof or may not reduce liver fat score. Some other times, it will only reduce liver-related deaths, but not cardiovascular deaths. So very clearly, you need to define what outcome am I looking at. And these are the 4 key things that you need to look at research questions. So for example, in the trial that we are following, the primary endpoint is normalization of hepatic echogenic response. That means they want people who have fatty liver disease to come to a point where there is normalization of hepatic echogenic response. And in the article, they have also clearly given how are they going to grade or score the ultrasound response. So they say that when you look at the liver and kidney, how should it look? It should have a score of 0. Similarly, for portal vein wall clarity, it should be 0. For posterior echo penetration, it should be 0. So for this level of clarity should be written in a manuscript. Now, you may not be a liver researcher, but you will understand that this goes into specifics. So when the authors say that we want a normal echogenic response, how are they going to measure it? That should be very clearly defined for any endpoint. Suppose if I say glycemic control, am I going to measure it with postprandial blood glucose, or am I going to measure it with HbA1c, or am I going to be simply satisfied with a fasting blood sugar? So those kind of things. So clearly when you say an endpoint, how is the endpoint measured? How are you going to score it or grade it? What will be the cutoff? Those are the things also that need to be clearly mentioned. So to summarize, whenever you look at research questions in any trial manuscript, you should look at whether the research question is well defined and if it is a very relevant research question. Now, how do you determine relevance? This is where you will have to read the introduction section of the paper and also try to look at available body of evidence in terms of whether there are any Cochrane systematic reviews which have already answered this question, or you may want to look at other systematic reviews published for the same research question. That is when you will know how relevant is this research question at this particular point in time. So do not forget, whenever you read a research paper, look at the research question, see for what population the research question is providing the answer. What are the specifics of the intervention in terms of dosage, duration, in terms of formulation, etc.? What is it actually compared against? And what outcomes are actually pre-specified by the investigators for which the answers are going to be provided? So moving forward, now you're very clear with what is the research question, what are the outcomes that you're interested in, what intervention is being tested. Now you need to move to the method section to understand if the results are likely to be valid. So when will the results that the authors are presenting will be considered as valid is when the methods are very, very good. So how to determine if the methods employed by the authors are good or not? So you need to look at both the design that the authors have, taken up in the study, how they have conducted the study, whether they have taken measures to minimize any bias, and how they have analyzed the study designs. Now, these are the key things that you should be very, very cautious when you read any clinical trial paper. If the methods are not appropriate, then automatically the level of trust that you have on that particular research finding goes down and down. Let's go one by one and look at these things in detail. The first thing that for any trial paper you need to look at is how was the randomization done? As all of us know, randomization is a critical part of a clinical trial or even a community trial. Now, what does randomization do? All of us know randomization is a process by which you allocate individuals into the various arms in such a way that they look or appear very similar. To be talking in a common parlance, the idea is to make all the treatment arms similar in characteristics which can either be measured or not measured. So first thing that you have to read the trial paper is to read and find out if the trial has done randomization in a proper manner. The next thing is the documentation or the written part of the randomization done really well? Another way to also look at if randomization is done properly is whether the intervention arm and the comparator arms are similar in characteristics that may matter for the outcome of interest. So these are some of the things that when you read the research paper, you should look very carefully at. For example, let's look at one paper which is described under the randomization section. It is just simply writing, patients were randomly drawn and assigned to alpha tocoretinol and placebo group. And then it goes on to talk about how the capsules were, and then how they were administered, and where the capsules were produced, etc. and etc. Now, from whatever is written here, if I ask you, how was the random number sequence generated? Was it generated on Excel? Was it generated on a specific software? Was it centrally generated, or did a statistician in the hospital generate this? You don't get any answers for any of these questions. Whether the sequence was a simple randomization, whether it was a block randomization, was there any stratification done? None of this is being explained by what is written in the written manuscript. Now, this is when you will understand that probably the randomization was either not done well or not documented well, and then definitely the level at which you will trust the results goes down a little bit. Now look at another trial. This is from the trial that we were reading. Here they say participants were randomized using a computer-generated random allocation sequence. So now you are very clear how it was done. It was done centrally through a computer-generated random sequence. You also know what type of randomization is being done. They say we are using a permuted block design. So that means block randomization is being done. Then they also say each block is made sure that the allocation ratio is 1:1, so that at any time you stop the trial, you will have equal number of people in both the intervention and the placebo arm. And then they go on to talk about other things. So if you write the randomization section well, then a trained reader of research work will understand that, okay, randomization has been done properly, and what type of randomization has been done, and the advantages of that apply to this paper. So always carefully go to the section which talks about randomization and then try to read that section with care. Now, many of you may have already heard about what are the consort guidelines. Consort guidelines are the set of guidelines that help in reporting randomized control trials. If you have not read about it, I urge you to go and download it and read about it. But the consort guidelines tells that whenever you report randomization, you need to report how was the random allocation sequence generated. That is the first thing that you should report, whether it is by a random number table, a computer generated one. What type are you using? Is it just a simple randomization, a block one, a restricted one? Is it a dynamic randomization, etc.? Then you also need to specify who is generating this sequence. Is it centrally done, or is it done by a biostatistician who's not part of the group, who's assigning the participants? And then who is enrolling the participants as well? So these things are very important when you're trying to see if the results are valid or if the methods can be trusted. So now that we have talked about randomization, let's move to the next section. The next section is concealing the allocation. Of course, you have generated the randomized sequence. Now, what will happen if either the person who's allocating the patient to the intervention or comparator arms, or if the participant can guess the random sequence? What do you think will happen? Can I stop here and ask Vaishnavi to open the chat box so that some people can answer? What do they think? And can you also help me read those answers? Are we getting any options or responses in the chat box? What do you think? Think for a minute. Yeah, somebody is saying it will create a bias. Yes, yes. But what type of bias? Very good. Somebody is saying it will create a selection bias. Yes, 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 yes. Yes, thank you. Yeah. So whenever, if suppose, let's say the clinician or the person who is randomly allocating people knows what is going to be the next sequence. Suppose it's going to the intervention arm or it's going to the control arm, then the person who's allocating now has the choice to allocate him to a particular group, which is exactly what you don't want when you do randomization. Because if suppose I am the clinician who's allocating the patient to either intervention or placebo arm, and I know the patient, and I know that this patient will benefit from vitamin E, then instead of going by the random number, I will put that patient in vitamin E, which then disturbs my benefit of randomization. So always, if the random number sequence can be guessed by anybody, then all the effort that you took for randomization goes to a waste. So whenever people are able to guess the allocation, it leads to selection bias. So if I know the knowledge of next assignment, then I will then select which patient should go based on my own inherent bias, based on my understanding of what the intervention will do. If I think vitamin E is beneficial, I'll put more patients there. If I think it's not beneficial, I'll probably move patients whom I know to the placebo group. So this is the kind of problem that you want to avoid. And always when you read clinical trial papers, you need to read if allocation concealment has been done well. So also there are published reports which say that when you have unclear allocation or inadequate allocation, then usually you end up overestimating effect sizes because you have already pre-selected good patients for the intervention arm, right? So that's exactly what you don't want to do. So what are the methods that usually people, in most papers you will find for allocation concealment? One of the methods that many people might have already read about is called snooze, which is sequentially numbered opaque sealed envelopes. The other method is to sequentially number the sequences in a container, which is all looking similar. And then the container is tamper-proof, and usually the pharmacy distributes the drugs. The other common way, which is now most common in most trials, is a central randomization, wherein whenever you enroll a new patient or recruit a new patient, you call or you send an email. So there is either an interactive voice response or an interactive web response, which will tell you which arm the patient should go to, whether it is A arm or B arm, or if you have more arms, then depending on that. So these are some of the methods which are acceptable methods. But then people find ways to get through the acceptable methods as well, which some of you might have seen this as well. Even if you have sequentially numbered opaque sealed envelopes, there is a tendency that people will read it against the light and try to know which group this patient is going to go. And if they have an understanding of whether B is placebo or not, then accordingly they will introduce selection bias. This is why in one of the famous papers from the Lancet Epidemiology series, they say how the snooze should be made. So the envelope should be sequentially opened, and before opening, the participant details should be written, and this will be captured by a sensitive carbon paper, which will transfer that information so that you don't change it. And then it also says a cardboard or an aluminum foil should be kept so that even if you put it against the light, like what it is shown in the figure, you don't find out what is the allocation sequence. So it is very important to conceal the allocation from the clinician who is, or the clinical trial coordinator who is going to assign the patients. Also, it is important to conceal it from the patients. The next important thing after allocation concealment is how to reduce other types of bias in clinical trials. Now, what do you think will happen when an investigator knows what treatment the participant is receiving? So let's say I am the investigator who already has figured out what treatment the participant is receiving. And suppose if I'm partial to that treatment, suppose if I like the manufacturer of that particular capsule, then what I would do, I will report better results for that particular group. That is exactly what you don't want, and therefore you don't want the investigator or the person who assesses the outcome to know what the participant is receiving, whether it is the active ingredient or the intervention, or whether it is the placebo or any other comparator. Now, sometimes what if the participant gets to know? That is another matter. Sometimes if the participant knows he is getting the placebo, there is a chance that the participant will drop out from your trial. because he or she knows that this is not going to be useful for his clinical complaint. The other way around is if the participant knows that he's receiving the active ingredient, and if you have a subjective assessment for outcome, they are likely to report that, oh, I have become better, right? I think I'm feeling better, which also you do not want. So this is again problematic. And as I said, if the outcome assessor knows, and if the outcome assessor is partial to the treatment, then again he will, if the outcome is subjective, he will make assessments like this. For example, even radiodiagnostic scoring is actually a little bit subjective, right? So if they want to report it, instead of a score of 0, and they will give a score of 1. So that is exactly what you don't want to happen. So what happens in these cases? If the investigator knows the treatment ahead, the investigator may add another treatment, which is called concomitant treatment bias, to improve the benefit for the patients. If the patient or if the assessor knows, then they will introduce their own bias, which we call measurement bias. But all of this will, at the end, give us wrong information about what is the effectiveness or efficacy of the intervention that we are measuring. So some of you might have seen, similar kind of, clip arts and other arts, where earlier people used to say, if only the patient doesn't know what they are receiving, then they call it single blind. And if the patient and the researcher don't know, then you blind both of them, that is double blind. Sometimes you blind also the statistician to what is the actual meaning of A, B, and C group. Then that is triple blind. But as of late, Consort is saying it is very confusing. Sometimes only when you blind the investigator, you can still call it single blind, right? So rather than saying single, double, and triple, you actually write clearly in the manuscript who is blinded to the intervention and how they have been blinded. So whenever you read a manuscript, make sure you read if there is any way that the researcher could have known what is the treatment. Is the participant actually unaware of the treatment, and if the outcome assessors were aware or not? And that will determine how much trust you will place on the results of the trial. So just to make the point clear, earlier we were discussing about allocation concealment. Now, allocation concealment, what does it do? Allocation concealment prevents investigators or patients from, selectively going to a particular arm of the trial. So it prevents selection bias. Whereas blinding actually prevents patients from or investigators from getting wrong information. Like I should not overstate the benefits or patients should not overstate the benefits. So this is the essential difference between these two things. And these are very important things in methods that you should read whenever you read a trial. The next thing that you need to look whenever you are reading a trial is to look at the completeness of follow-up. Now, most of the trials that you might have read, or, I can say more than 90% or even 95% of the trials would have definitely some loss to follow-up. But what is critical is for you to see if there are any differences in the loss to follow-up between the intervention arm and the comparator arm. Let us say, if suppose there are a lot of people who are, dropping out from the intervention, then you should see if there is any adverse event or side effect as a result of which they are moving away from the trial. Or is it that they know that this is not beneficial, let me go out. More so when people guess that it is a placebo, they will drop out from the trial because they see that there is no benefit. So whenever you see a differential loss to follow-up between intervention and control arm, you should be very cautious and you should actually investigate why this is happening. When you read the paper also, you should be very cautious because this now makes both the intervention and the comparator arm not similar after you have taken so much pains to randomize. So you did all of that good randomization, made the intervention and control groups similar in all forms. Now, after introducing the treatment, now people are dropping out differentially and introducing post-randomization selection bias. So that is something that you should be mindful when you read the manuscript. So when you read manuscript, please see if everyone in the trial is described and followed up. How are the numbers loss in each group? are the laws similar or is it different? If different, are some reasons explained? If not, you may want to either write to the author or see if it is explained in any section. So where do you actually see this? So consort or many trials, because they follow the consort requirements, the first thing that you do is figure 1 is a flow chart which tells you how the patient has flowed starting from assessment of eligibility. So you can see in the trial that we have been following, the vitamin E for NAFLD patients trial, they have assessed 180 people who are assessed for eligibility. They then, included and excluded people for various reasons. Finally, they allocated 43 patients to the intervention and 44 patients to the placebo arm. Then when they followed up, they have said 13 people dropped down from here and 10 people dropped, and they have given various reasons. Some of them withdrew, some of them had protocol violations, some of them missed ultrasound, similar reasons here. So you have to be now cautious why these 8 and why these 6, whether it is written elsewhere in the manuscript. So this particular diagram actually will tell you and will give you clues as to why is there incomplete follow-up, right? So is there any post-randomization selection bias or not? Moving forward, there should also be similar frequency and timing of follow-up in both the arms. It should not happen that you frequently follow up people in the intervention arm and then leave the placebo arm just like that. So whatever interactions and meetings and assessments and lab results that you're doing for the intervention, same thing should be done in the same frequency and timing for the people who are there in the comparator and the control arm. They should also assess the outcomes as well as adverse event reporting in the same manner for both groups. Only then you will understand whether whatever difference is seen is actually because of the intervention or whether it is not because of the intervention. If you are going to give any supplementary treatment, then that also should be given to both the arms. So it should never be given differentially. So that is what I mean by equal treatment of both groups. Not that means giving the same treatment in both groups. It means both the groups are treated in the same way in terms of frequency and timing of follow-up, in terms of how outcome is assessed, in terms of what other treatments are being given. Now that we have looked at, conduct of the trial, so we looked at design in terms of randomization and allocation concealment. We looked at conduct of the trial in terms of blinding, in terms of completeness of follow-up, in terms of whether the frequency and the treatment given to both the arms are similar. Now we are going to see how the trial is analyzed. Now this again is very important because analyzing the trial also some problems may be there. First question that you need to ask or you need to carefully read the analysis section is, where is the group analyzed in the same fashion as they were randomized? So analysis as randomized or not is the first thing. The next thing you need to do is, was the analysis pre-specified and appropriate? So these are two things. Now, where do you get to know what is the pre-specified analysis? Most of the papers will give you the CTRI link. So you can actually find out what was the analysis that was pre-specified, because selective reporting of analysis happens. In many journals, it happens where people don't actually report how they have specified in the protocol. This is something that you need to check so that you can be very trusting of whatever the results the authors are presenting. But the major problem is in the first one. Is the analysis done as per the group to which they have been randomized or not? Now, why is it important to analyze in the same group as they were randomized? The question can come to you, why not analyze the groups as per the treatment? Because when you follow up in trials, sometimes people don't take whatever treatment you are giving, they may take the other treatment in the comparator arm. You don't want to do that because whenever you analyze as randomized, which technically is called as intention to treat analysis, you retain all the benefits of randomization. Because now you know that your intervention arm is completely exchangeable to your comparator arm. If suppose you make any changes during analysis, if suppose you don't analyze the groups as per the randomization, but as per actually what drugs they have received, then you are violating the benefits of randomization. This generally happens in some trials for various reasons. If you have allocated them to, let's say, vitamin E, then they may end up in some other group which is giving metformin, right? Because patient or because of the investigator, because of their preferences or something. But when you do analysis, that patient should be considered in the arm to which they were randomized, because otherwise the benefit of randomization is completely lost. So this is something that you should see if intention to treat analysis has been done or not. One of the things about intention to treat is it offers you a conservative estimate of what is the effect of the particular drug or other intervention that you're testing, which is good because you don't want to unnecessarily overestimate the benefit of any drug. It is okay to be conservative in your analysis as long as you're analyzing it correctly. There may be some journals that you read or in many other trials where you would have heard about per protocol. Now, what is per protocol is you forget about the groups to which they were randomized, but you analyze based on what actually the patient received. Now, here the problem is you lose all the advantages of randomization. Now, the exchangeability is totally lost. But what it can give you is it can give you actually an estimate of efficacy. Now, many of you know that efficacy is the effect of the drug in a controlled clinical setting, whereas effectiveness is more pragmatic and practical settings one. So per protocol sometimes gives you efficacy, and many a times when you are trying to look at risk for adverse events, it is a good idea not to underestimate and therefore go for per protocol analysis. Because unlike a treatment's beneficial effect, where you can still agree to a conservative estimate of the benefit, it is very wrong to get a conservative estimate of adverse events happening. It is always good to know exactly what is the risk of adverse events, and therefore doing a per protocol analysis here is beneficial. So always look carefully at what is the analysis that is being done. Is it intention to treat? Is it per protocol? Is it correct? Is it relevant? And if suppose they are going to do per protocol, then anyway the randomization is lost. So are they going to adjust for known confounders, measured confounders? Those are the things that you need to look very carefully. Now that we have discussed what are the various things that you should read in the methods section. So we discussed about randomization, allocation, concealment, blinding, follow-up completeness. We also discussed about the analysis plan and how analysis has been done. We now move to the section where we are looking at the results. Now, the things that you want to know is what do these results actually mean and how precise they are, right? So how large was the effect? Is the effect measured in relative measures? Relative means is the risk ratio given or the incidence rate ratio given, or absolute difference means is it a risk difference that is being presented? And the other important thing that you should also look is the result may be statistically significant, but does it make clinical sense for me or not? Is it going to be clinically meaningful or beneficial? And also you should be looking at how precise this is. These are the things that are going to answer you questions about whether this result is beneficial or not. Let's look at it one by one. For example, let's have a look at the study that we have been following. This is the vitamin E versus placebo trial. When you look at this table, which is presented in this manuscript, they have said that among the group which received the tocoretinols, which is vitamin E, you can see that out of all the treated patients, 34.9% returned to have normal echogenic response versus only 18.2% in the placebo group. And what they are telling me is, they are telling that this is statistically significant because many of us know that P less than 0.05 is a statistically significant result. Now, this result, P less than 0.05, does not really tell me how beneficial is tocoretinol. How much does it reduce the risk, or what is the likelihood of the patient with NAFLD and hyperlipidemia returning to have a normal echogenic response because of tocoretinols? So if you actually want to do a good analysis, ideally you should present the results in the form of risk in the exposed, risk in the unexposed, and relative risk. Now, based on the results, I have inputted the data into a software which is called OpenEpi, and I have got these results. Now, let us look at what this result means carefully and slowly. The first thing that I have highlighted is risk in the exposed. Now, what does risk in the exposed mean for the study that we have been following? It means how likely is that participant who received vitamin E to have normal echogenicity at the end of the trial. So what is the answer for that? 34.88%. That means if I have put 100 people on the vitamin E intervention, at the end of the trial, 34 people are likely to have normal echogenicity. So this you can observe, and this is a very meaningful thing for a clinician because you now know, okay, if I put 100 people on this, then nearly 1/3 of the people are going to have normal echogenicity as per the result of this particular trial. The next thing you need to know is what is it in the people who received the comparator or the unexposed or the placebo group. So when you look at the next line which I have highlighted, that answers the question, how likely is it that the person who is in the placebo group will have normal echogenicity? Now from this trial's result, it appears like if you put 100 people on placebo, 18 of them have normal echogenicity at the end of the trial. The next question that comes to my mind is, what about the risk ratio? What does it tell me? It tells me as compared to a person who is receiving placebo, how much more likely is a person who is receiving the intervention to have the outcome of interest, which is normal echogenicity. So it tells me the answer is 1.9. So if you can roughly take it as 2, it tells me that a person who is receiving the intervention is 2 times more likely to have normal echogenicity as compared to a person who is receiving the placebo. Now, this gives a clinician or a researcher a good idea of what is the magnitude of the effect. A p-value does not give you what is the magnitude of effect. Whereas when you look at risk ratio or when you look at risk difference, you get the magnitude of effect, or rather what we call as the effect size. Also, the earlier ones which we discussed, the risk in exposed and risk in unexposed, also gives you a clear idea of what will be the effect in individual groups. Now, instead of ratio, if you want to look at risk difference, now what does it tell me? It answers the question, in absolute terms, how many more persons who receive the intervention will have the desired outcome when you compare with the people who receive the placebo. To explain it simply, if I put 100 people on the intervention arm and 100 people in the comparator or the placebo arm, how many more people will be there in the intervention arm as compared to placebo arm who would have achieved a normal echogenicity? The answer to that question is 16 more people would have achieved normal echogenicity as per this particular trial result. Now, the other thing that you also want to know is what is the width of the confidence interval, or how precise is this estimate? Now, if you look at this estimate for risk difference, it is ranging from minus 1.5 to 34.94, which is a very wide gap. Now, when you have wide confidence intervals, it is because the number of people who are studied are relatively less. In this particular study, it was roughly about 88 or 87 people who were studied together, all together in the intervention and comparator arm. Suppose if there is another study which is going to show this as 8 to 22, then you will be better confident about the results because the confidence interval is much more narrow. So you have got much less variation in what the results could be, right? So this is another thing that you should actually look at results, not only the point estimate, which we were looking previously, but also the confidence intervals. So now that you have looked at the results, now you have understood, okay, what does the result mean? What does it mean if I put 100 people on intervention, how many are likely to become normal echogenicity? If I put 100 people on placebo, how many are likely to become normal echogenicity? Now you know in relative terms whether this particular intervention is likely looking like a beneficial intervention or not. The next question that you need to ask is, if suppose this intervention is not beneficial, you also need to ascertain why it is not beneficial. One of the reasons that a result may come out to be not clinically significant or not statistically significant is when you don't have sufficient people being studied. That means the sample size is not sufficient. So the next thing that you need to look at a trial is to look at sufficiency of sample size. Now, sample size calculation is a very technical thing, but at least you should read that section to understand how they have calculated sample size. For instance, in this trial that we have been following, they simply wrote, for prospective estimation of sample size for a binary outcome trial at 5% level of alpha and 80% power, we have calculated according to this clinical trial book, and we have planned to include 20 people. Which in essence, even if you don't know anything about sample size, seems like they have not calculated sample size correctly. So when you don't have a correct sample size calculation and the numbers are very small, you are likely to have a very imprecise result, which is what happened. Though the point estimate told you that it is likely beneficial, the precision seems to be very wide in whatever results you have seen. So what I did is, using the trial results that came out from the trial, if you put it on again OpenEpi and try to calculate sample size, so you know that 18% of the placebo arm, which is unexposed with outcome, had the normal echogenicity and 35% had it in the intervention arm. And if you put your normal assumptions of two-sided confidence as 95 and power as 80, you tend to require 242 people to actually have sufficient power to study this result, which this particular study did not have. For this particular study, you can also do a post-hoc power calculation, which I'm not showing. But these are the things which will tell you why the precision is like this. So always remember, apart from your alpha and beta error, you should also know the effect measure in terms of what proportion had the outcome from a previous study and what proportion of the exposed had the outcome to calculate sample size. If all of these parameters are not mentioned in the sample size column, then definitely there is something wrong with how sample size has been calculated. And if it is lesser than the required, then your results are likely to come out to be negative. When in actual reality, it may be positive, you do not know. So that is the reason why you need to look at sample size. Finally, now that you have read the results, understood what the results mean, and looked at whether the size is sufficient for the results, you also need to know who the results are applicable to. Now, this is a very simple question because you already know that you looked at the population in great detail when they had described the inclusion and exclusion criteria. So whenever you read any trial result, you should know that the results are applicable to the kind of people who were participants in the trial. So look closely at the inclusion and exclusion criteria, and they are the kind of people or patients for whom whatever results, if the results have come positive, they are applicable only for that group of patients. Another way to look closely to know who are the patient groups is to look at the table 2. Most of the times, the trial table 2 is going to tell you what are the characteristics of people in the intervention and control arm. In the trial that we have been following, this is what is it. So if you look at it, you will know how many proportion of people were overweight, underweight. You can see that most of the patients have got, this is the level of liver enzymes. So a clinician or even a researcher who's reading the paper will have a pretty good idea of what is the kind of people who have been studied, and this is the kind of people for whom the study results are applicable. And you cannot, apply the study result to a different group, which may have steatohepatitis, or a different group which has cirrhosis, etc. So to summarize, what we have been doing in today's session is we have been trying to read how to read a research paper, especially one of a simple clinical trial. First thing is you need to look very closely at the research question, see whether the research question is clearly defined, understand what intervention are you going to look at the results for. That is very important, and against what it is compared to, and who are the people on whom the study is actually being conducted, and what outcomes for which the effectiveness or the efficacy is established. The next thing you want to look at is how to know whether the results are good enough or whether I can trust them. For that, you need to look at both the design, the conduct, and the analysis, where we talked about randomization, allocation concealment, we talked about blinding, follow-up completeness. We also talked about how analysis is designed and whether it is pre-specified, correctly done, whether it's an intention to treat or a per protocol, etc. Nextly, you also need to understand and interpret the results. So whenever you read a trial result, it is important for you to know what is the likelihood of achieving a good result among the people who received the intervention and among the people who received the control. And whether both the groups are having meaningful differences, both clinically as well as statistically. And the final way is to look at whether the size is measured correctly, etc. And also to know to whom these results can be applied, so that you apply it to the right group of patients, the same kind of group which has been studied. So what we did not talk about are, higher level concepts about trials like superiority, equivalence, non-inferiority, and various other trial designs like cluster randomization, crossover trials. We also did not discuss about how to actually quantify risk of bias, which is given through the Cochrane group. And we also did not talk about grading of evidence, which usually comes as part of systematic reviews. So with this, I will stop, and I thank you for your attention, and I turn it over to the moderators, please. Thank you.
Oh, amazing. Thank you, Dr. Archana. That was quite a masterclass, I have to say. I mean, 1 hour of session and interestingly, we have still got about 150 participants, listening to you, and we have
Okay.
a lot of questions. So, if I may start off with a few
Sure.
questions.
Yes,
So,
sir.
Krishna Kumar is asking, what are the tools available to do a critical appraisal of a manuscript?
So one of the things that I would see, there are several tools, sir, but one of the things that many people use is the consort statement itself. So the consort statement actually helps researchers to write manuscript. It also helps researchers to critically appraise it. So I would say the easiest one to look at is to look at the consort guidelines, see if the paper is actually conforming to it, and what are the things that are missing, and how the missing things can affect your interpretation of results. So that's the easiest way to look at it.
So the next question is Rahul Pal is asking, what is post hoc analysis? When is it required?
So many a times post hoc analysis we do, for example, in this particular trial, it had a very imprecise result. So sometimes post hoc power calculation we do to see if this number, if it's studied, does it have adequate power to say whether the treatment will be effective or not. So that is somewhere where we do post hoc power analysis to understand if the size is sufficient. Because as readers, we don't know how the size was calculated. So that's something that can be done. Yes, that's one place.
Dr. Anisha is asking, what if the paper doesn't mention exclusion criteria? I think you mentioned about exclusion criteria, right?
Yeah.
What doesn't mention the exclusion criteria? How do we take it?
Sure, there is no other thing that you can do that will raise suspicion in your mind as to who were excluded. So that is the only option. If you were a reviewer for that manuscript, then you can probably write that as a question and ask from the authors before it is published. But if it is a published manuscript, it can only raise questions in your mind. That means the reporting is not proper. Maybe you can write, if it is a serious thing, you can write to the editor, because now many journals do allow you to comment on manuscripts. Yeah.
The next is Sundana Kaila is asking, is it ethical to use placebo to the patients in a trial?
One of the things that at the beginning of the trial itself we have to establish is whether there is clinical equipoise in the question that we are asking. Now, what is clinical equipoise is among the group of, the clinicians or the experts in that particular field, is there really a doubt in the mind as to whether this intervention is useful or not? So only when there is a real doubt as to whether the intervention is useful, one, the trial is ethical to do. Two, if you are not really sure of any other, efficacious medication, then obviously you have to go for a placebo. If you know of other treatments that have offered some benefit, it is always good to have another treatment or the standard of care as the comparator. So placebo is justified because without a comparator group, you cannot say whether this group intervention is actually the one which is resulting in results or not. So comparator group is definitely required. Yeah.
So Chinmay is asking a difference between simple and block randomization.
So one of the places where you do block randomization is when you specially have a small sample size. Suppose you are doing a trial with 30-30 in each arm. And suppose in between you find that there are a lot of adverse events, and suppose if your data safety monitoring board says stop the trial. You don't want unequal distribution of participants in each group. So what block randomization does is it divides your total sample size into blocks, and of course the block sizes are specified. And within each block, it tries to equally allocate people to the intervention and control arm. So that if for whatever reason you stop the trial in between, you still have equal numbers in both intervention and control. Whereas a simple randomization will not do that for you. So for if you want further explanation, if you actually use an experiment at your home, if you keep on tossing, let's say flipping a coin, you flip it for 5 times, you won't have equal numbers of heads and tails. But if you flip it for 100 times, it will actually be equal. So whenever the size is small, even though flipping a coin is a random method, it will actually tend to go to one side, right? So you will have unequal distribution in both groups. So that is when a block randomization helps, because it will divide your sample size into blocks. And then within each block, it will allocate equally. So that's the benefit. So if your sample size is small, definitely you should go for block randomization. Yeah.
Akshay is asking, what is the value of open label RCTs?
So open label RCTs, sometimes they are done. For example, let's say you're giving a nutrition intervention trial. Let's say you're giving a low carb trial. There is no way you can hide that from the participant, right? The participant knows that what he is eating is low carb. The investigator knows that what he is giving is low carb. There is no way you can. So there are a lot of situations where you will have to do open label trials when you can't actually blind anyone to it. So it is okay. I mean, it depends on your question. Yeah.
Sundana is asking us, how can we address chance of contamination?
Yes, there can be. Like, for example, in this particular trial, at least, there is no question of contamination because the pharmacy has actually prepared those drugs. You have labeled those containers. So obviously, people are not going to take some other container drug. Whereas if it is in a community intervention, let's say you are giving it to a group of ashas. If their friends are some other group of ashas in the control arm, the information may likely pass. So it depends on what your intervention is. You need to design your study to avoid contamination. Now, how contamination of intervention can happen is setting specific. But you should write in the methods how you have avoided it. Yeah. Yes.
So Akshay again is asking, so if patients violate the randomization and use comparator arm treatment despite being in the intervention arm, do they still have to be analyzed or excluded from the study?
No, they still have to be analyzed as intention to treat. Many a times, if you see, especially in the trials, like for example, in MI patients, etc., you might have put them on the drug arm and not on the arm which is receiving any invasive intervention. But they might have worsened over time and then you might have moved them to the other arm. But still, if you want to maintain the benefits of randomization, you do an intention to treat analysis. Of course, it provides conservative results. We know that it provides conservative results, but then it benefits that exchangeability that you establish through randomization. Yeah.
I don't know what this means though, but please provide some instances where readers might misinterpret information.
Yeah, a lot of reasons why readers might misinterpret. So while reading the results itself, many a times the figures may be, written in such a way the axis may be changed so that you will observe that there is a large benefit. Whereas if you look closely, it may be only like 2 points or 3 points, but the axis may be, 0.1, 0.2, 0.3. So many a times it may appear like a large benefit. So you have to be very closely observant when you read any section in any manuscript. So that's why a lot of people say that you have to wear the critical lens when you read manuscripts, not to be critical of the authors. We know it's very difficult to do trials. Yes. Yeah.
Devaraj is asking us, is it necessary to check research question and study objective or only research question?
No, I mean, both are essentially like complementary to each other. No, your objectives are derived from your research questions only. So ideally, a well-structured objective for at least a trial should have all the PICOS component. It should show what is the population, what is the intervention, what is the comparator, and the outcome. So whether the researchers write it as a question or whether the researchers write it as an objective is okay. Yeah.
There's something in the chat box. Let me just check. Does the effect size justify changing practice?
So, like, as I said, one of the things that we did not touch upon is clinically meaningful benefit. For example, this only the clinical counterparts can tell you, right? For example, I know from being a hypertension researcher that if a particular intervention reduces 5 millimeters of systolic blood pressure, then I know that that is a clinically relevant benefit. So when I see a risk difference or a reduction in the blood pressure of 5 millimeter, I know that this is a meaningful difference. So if your effect size as per whatever study you have done. So if there is an NAFLD researcher, then that person can tell. And to my mind, this seems to be a good effect size, of, actually having almost 34% coming to normal echogenicity. But then that is contingent because they have taken only people who are in the lower grades of fatty liver and not really patients who are steatohepatitis. And of course, the result is not statistically significant. So there are a lot of problems with this trial as well. But then you have to take all of that into consideration before you decide what you want to do. Yes.
If we plan for per protocol analysis, but end up in doing intention to treat analysis for some patients, then how can we present the results?
No. Ideally, it is not about how analysis is completely in your hand, right? And the preferred analysis is intention to treat. Though you know that some patients will likely to receive the comparator arm treatment for whatever reasons, like the example in which I gave, a patient who's on having MI, suppose he has a re-attack and you want to do revascularization, you cannot continue him in the drug arm. So that is bound to happen. But then some of the even consort statement advocates, in such cases, you present both intention to treat and per protocol analysis, and then allow the readers to make the interpretation. So the readers do know that per protocol doesn't have the randomization benefits. Both the groups are not equal. The other way to look at it is some authors may even adjust for the confounders which have now become different in both the arms in the per protocol analysis. So different people do this differently, but it is good to have a look at both if you think that considerable people have moved away from the treatment that they were supposed to receive. Yeah.
So Jeevan is asking us, when can we do an interim analysis?
Many clinical trials do interim analysis, but the researchers don't do it. It is actually done by the data safety monitoring boards. So usually if it is a large trial, if it is a drug trial, then you definitely have a group which is called data safety monitoring board. They look at trials in pre-specified intervals. And of course, they also calculate sample size for those and adjust accordingly. And the alpha level at which they do the analysis keeps varying because now they are looking at a smaller size. So those kind of analysis are routinely done in drug trials, but not done by the researchers. They are done by the data safety monitoring board to take a decision if at all, let us say we need to stop this trial interim because there is a lot of adverse events. Or let's say we have to stop this trial because it is becoming too much beneficial, like the penicillin thing. If suppose it's so effective, then there is no point that stopping other people from getting it. So that decisions are taken by the data safety monitoring board. And yes, they do interim analysis. Yeah.
Okay, I'm just going to close with just a couple more questions.
Sure.
In clinical trials, only two arms, intervention and control, are possible, or three arms is possible?
No, there are several trials with even 4 arms. Multiple arms are possible, but then with multiple groups, the way you analyze is going to be different. So multiple analysis, statistical analysis will reduce alpha. So accordingly, you have to take measures. So since we had only 1 hour, that's why I didn't cover those complex trials because then it will be very difficult for us to discuss. Yeah. Yes, but it is possible. Yes.
And then, finally, could you suggest some papers on clinical trials which we could apply what we've learned, might help in hands-on practice?
No, you should definitely first read the consort published paper. That will give you a good idea because it gives you the guidelines of how to report, but also it explains to you what randomization is. It explains to you what allocation concealment is. So most of the concepts also get explained. So instead of looking at the checklist, you look at the elaboration papers, which is published in all major journals, including BMJ, NEJM, Lancet, everything has these papers. Or you can also visit websites where these are published. So you can go and visit. First, you look at the consort guidelines, understand clinical trials, then refer to textbooks which talk about clinical trials. And then you can read papers and get further. Yeah.
Amazing. I think we really have to close. Otherwise, I think questions are just keep flowing. Um,
Yes.
Thank you very much once again, and on all the attendees again, thank you very much. The idea of this PRISM talk is to keep yourself engaged, collaborate, write to us, and of course, there's always a survey, which is already a survey which is sent to you. Please fill up the survey so that we can get more topics for you, more speakers for you, and please tune in again next month. And a big thank you again to Dr. Archana from ICMR. Hope you all enjoyed the evening and have a good evening. Thank you very much again. Thank you, Dr. Archana.